Dear ladies and gentlemen, welcome back. Panel number 4 is dedicated for the two techniques, interventional approaches for the pain management. What they are absolutely number one in the operations theater, choosing by the many doctors in Europe and around the world. My name is Edmund Kiełbasa. Let me introduce our faculties of this panel. Dr Przemysław Strulak, consultant anesthesiologist, pain management specialist, chief of the wards of the pain management department in the beautiful place in small city close to Zurich, Uri, in Canton Hospital. You have to know, because probably not so many people knows, Uri is well-known places where was born Wilhelm Tell. That's, if somebody's remember who was the Wilhelm Tell, he came from Uri. Probably Przemek will send a few words about that. Przemek is a consultant who's working, who we know him more than 15 years. We met together with pain specialists who used radio frequency and the different techniques. And start 15 years ago, Przemek introduced a lot of efforts to bring the cryoneurolisis like a alternative and the more chosen procedures right now. Another one, our speaker faculty is Dr. Igor Filipowski. Dr. Igor Filipowski came from Copenhagen, from Denmark. He is a pain consultant. He's a pain doctor. He's the anesthesiologist. Igor is working in private center right now, Copenhagen Cryo Center, what a lot of people recognize, like not only the center for the procedure, but also for the education's manner. Igor is a president of the International Society of Ultrasound Guided Cryoneurolisis. Przemek Strulak is also board of this society. This panel is dedicated, as I mentioned before, for the two techniques, thermo lesion, thermoablations, and the cryoneurolisis. More than welcome, dear doctors.
Hello.
Thank you. Hello.
Okay, we try following by the some kind of questions to introduce our participants to the panel. The first my question is, what is the main mechanism of actions of thermal lesions and the cryoneuro lesions and the pain treatment? The question is regarding of the definitions of the both method and their mechanism and of actions of the nerve tissue. Przemek, please say a few words about that regarding of the radio frequency.
Well, we have two kind of radio frequencies. We have actually a continuous radio frequency. It's a thermolation, which is conducted with a high temperature. It works by distracting nerve tissue via extreme high temperature between 60 and 100 degrees Celsius. Usually the used temperatures are between 60 and 90 degrees. And then you have the pulse radio frequency, which is a non-ablative neuromodulating way of treating pain with the electric current. The fields that are produced with the 42 degrees Celsius application make an axonal membrane change of the potentials change of the axonal membrane. It works on the C and A nociceptive fibers, and it's a modulating procedure. It's like direct neuromodulation. The continuous radio frequency thermal lesion actually is supposed to this is a very discussed point, is supposed to cause the Valerian degeneration. That's the same thing that happens with the cryo of the afferent nerve fibers. The problem is that not always it ends up like that, and very often the epineuron and perineuron are damaged. So you have a partial destruction of the nerves, and they do not regenerate. The result of this treatment is the interruption of the pain signal transmission. And again, the pulsatile frequency is a neuromodulative way of treating pain.
Thank you so much. Thank you so much for your explanations. I will go more deeply in these questions for the next part of the questions, but the same question goes to Igor regarding mechanism of the cryoneurolysis, the pain treatments. Please, Igor.
Yes, cryoneurolysis is a treatment when we use the low temperature to modulate the nerve or cause the axon disruption. When we comparing to radio frequency, when we use cryoneurolysis, we are exposing the nerve on the temperature in between -60 to -80 degrees, which is like between -20, -100 is the safe window where we can easily actually freeze the nerve, and then cause axon disruption. We are preserving the epi and perineurium, and then the nerve regeneration actually is allowing after the treatment. The difference between when you use cryoneurolysis, the effect is immediate. The effect is like local anesthetic, but lasts much longer. We can use it on all nerves. So we are not limited to only A or C fibers. We can use all myelinated nerves, big nerves, neuromas, all type of nerves, mixed nerves. And then there is no risk of neuroma formation, which is the best option with cryoneurolysis. The other thing is that if we use cryoneurolysis preoperatively, we have what we used to call like therapeutic window postoperative for physiotherapy, which will last up to 6 months after the treatment. So this is my most important things when we take in consideration cryoneurolysis for treating pain, acute or chronic pain.
Okay, thank you so much, Igor, for that 100% explanations. But I would like to go a little bit deeply for the mechanism of actions, because that's questions, they are coming very frequently and very often from the other doctors, what they are not so familiar yet in the interventional procedures, and generally they are asking for some questions what is quite difficult to find it with the evidence explanations. That's the reason I would like to go a little bit deep in these things. And could you explain us exactly what's going on with the nerve structures when we are hitting the nerves or we are cooling the nerves? It means what's happened with the nerves after using the physical current or low temperature. Przemek.
Okay, so I'll start with the RF. You have actually three kinds of RF. You have the normal RF, which is working in the margin of 80 to 100 degrees. Actually, 100 degrees is not being used. It's like 80, 90 degrees. Then you have the cooled RF, which means that the tip of the needle is being cooled for the time of the procedure, which actually allows to have a much bigger range of treatment with the RF, and the temperature is held about 60 to 70 degrees. And then you have also the possibility of pulse radio frequency, which is in the margin of 42 to 45 degrees, where you have actually a modulation, and you do not destruct, but you actually do the same thing that you do in the neuromodulation. You modulate the pain fibers. So that would be about the RF. If you choose the temperature between 45 and 50 degrees, you have actually a reversible conduction block. If you choose the temperature between 60 and 70 degrees, you have a irreversible axonal and myelin damage. And if you use over 80, you have actually a coagulative necrosis of all neural and connective elements, which means that the possibility that you get after this treatment neuropathic pain is much higher. So this is the range where the RF this is the most discussed point, because some say with 80 degrees you still do not have the possibility to get neuropathic pain. But in my practice, I have very often seen that this is the case, and this is actually the moment you should start talking about cryo, because this is an area where cryo, that's my opinion, would have a better place in medical treatment. So maybe
It's
Igor could say.
nice. It is nice explanations. When before the same question to Igor, I would like go just a little bit more deeply. It means to understand better this phenomenon. When we have the temperatures over the 60 degree, like a 70, 80 degree, what is the connecting with the classical radio frequency or cool radio frequency, I suppose, we are achieve effect of the ablations, right, of the nerves, and generally ablations. There is the very big definitions, but generally we burn the nerve and we destroyed exactly the nerve, not only the axon, but we destroyed also the epineurum, perineurium. It is also kind of risk to distract surrounding tissues, what I understand. I'm right, Przemek?
Yeah, you have actually not only axonal, but you have myelin damage. So you have actually with the temperature between 60 and 70, and with
Okay.
80 over everything over 80 degrees, you have a necrosis, which means you have
Okay.
a total destruction. Yeah.
This is the something what we are not looking. That you are not looking during the procedure. Okay, thank you. Thank you for that explanations, Igor. Your turn regarded this mechanism of actions of the cryoneurolizer, focusing directly for the nerve tissues and myelin sheets, also the surrounding tissue, what is also important. Please, Igor.
Yes, the huge difference or main difference between cryo and radiofrequency is that when we are doing cryoneurolisis, we are only actually freezing the axons. We are freezing the intracellular water into the axons, and then we provoke the axons breakdown. Afterwards, we create the process which is called Wallerian degeneration. And when this, let's call it like inflammation process, starts up, so we have the macrophages come in and clear this debris, and then we actually have the start of the beginning of the regrowing of the nerve, which is happening 1 to 2 millimeter per day. And the difference between cryo and radiofrequency is that with cryo, you cannot actually cut the nerve. This is where the problem with radiofrequency actually comes. And then the other thing is that with cryo, we cannot provoke neuritis or inflammation of the nerve, because, and this is where this condition is very difficult to treat when we do radiofrequency. So that's why this is one advantage with the cryo. The other thing with cryo is you can use cryo actually everywhere on the body, on the small nerves, on the sensory nerves, motor branches. We use a lot of cryo for spasticity at the moment on the motor branches of the nerve, intramuscular branches, and we can see actually that the nerve grows back. There is no risk of freezing the surrounding tissue because there is a huge temperature, a heat exchange between the cooling effect and the warming from the arteries. Sometimes we add some additional water, saline, or some local anesthetics in order to create bigger lesion. but usually it's enough to just to freeze the nerve and then we and use the intracellular water of the patient. So we don't add any other condition. The other advantage of cryo is that cryo is you can control the cryo because the lesion is actually controllable because you have only 1 centimeter or 1.5 centimeters where you freeze. With radio frequency, you cannot control the heat. You cannot point the heat in direction where you want to be. With cryo, we are very limited actually on the nerve, and then we are freezing the nerve. Because of the temperature gradient, we cannot freeze the fat tissue, we cannot freeze the muscles, we cannot freeze the vessels because there is blood circulation. So when the blood circulates around the cooling effect, so it's actually it takes the cooling out or away from the place where we freeze. So that's why the risk of freezing is very low.
Thank you, Igor. Very nice explanations. And Przemek, I will give you the microphone right now, but I'm just following by that. If we burn, or if you are doing ablations, or if you are doing cryoneuralysis processes in the nerve tissue, how the nerve looks and how the regenerating of the nerves goes after the certain procedure. Przemek, radiofrequency.
I have to go back to the radio frequency, please. You have to differentiate between the pulse radio frequency. So we have to, if we will compare anything here, we can compare cryo with pulse with RF with radio frequency. That means using high temperatures. If you are using pulse radio frequency, this is a totally different way of treatment, and it is a treatment which is actually a treatment I integrated in a treatment where I do cryo and I do pulse radio frequency too. RF has other indications. Pulse radio frequency has. So please don't put that in one box, because that would sound like we're putting the whole treatment with radio frequency in one box. Now, coming back to your question, what was your question once again, please?
Okay, that's your explanations is correlating with the next my questions. That's we are come back for your explanation. But previous my question, it was how the nerve structures looks and how the nerves regenerate after using the highest temperatures. And we are focusing right now also only for the thermal damage, like a cool radio frequency or classical radio frequency, how the nerves looks after the thermal lesions and how the nerve regenerate.
Well, as I said, this is a coagulative necrosis, which means you destroy the nerve. All structures of the nerve are being destroyed, and you give the nerve the possibility, with using a temperature about 80 degrees, to regenerate, because it's supposed to not be displaced. Okay, I'm
Okay.
talking about the ideal situation, not the situation that happens from time to time. What the target is of the thermoablation is the permanent destruction of the axons, which means you destroy them because you want them to stop working. You don't want them to regenerate again, and regeneration is combined with a fibrosis. That means some of the axons start working again, and some of them don't start working, and they are changed to fibrotically. So you cause actually a damage to the nerve. And that's why there is always a possibility, when you're doing thermal ablations, that you will get neuropathy. You get like a phantom pain because the nerve is partly destroyed. Okay.
Okay,
So
it's connecting with the patients, or is it connecting more with the techniques?
No, that's absolutely with patients. If you denervate facet joints with 80 degrees Celsius, what you're doing is you're actually causing a coagulative necrosis of the medial branches. And in most of the cases, a long time after, that's maybe the better thing for the patients, which means about 12 months later, 8 to 12 months later, the medial branches regenerate, but they never regenerate in the form they have been before. A part of them gets permanently destroyed, which you
Okay.
don't have in the cryo.
Okay. Igor, cryo, please. The same question, the same
Yes,
points.
and the difference is that when we treat medial branch for facet joint pain, so we can find the nerve actually 1 year after on the same place. I have patient now which was treated 3 years ago with radiofrequency. Unfortunately, he has a permanent damage on the nerves, but the problem is now the pain is back and we cannot stimulate the nerve. So now I'm trying to find out where the nerve regrows because it's not in the place where it should be. So when we treat to come back to your question, Edmund, when we treat peripheral nerves, so during the treatment and just after the cryo procedure, we can see that the nerve is swollen. We can see edema on the nerve, and this is actually a very important sign to see with ultrasound. So you can see actually that we have provoked the Valerian degeneration, because if we don't, the nerve damage is happening during the cryoneuralisis and it's happening during the process of defrosing, of thawing period. So that's why it's very important to actually say always that after the freezing, we have to have like 1.5 2 minutes of defrosing, where the axon breakdown is happening again, or to export once again or on 3 minutes freezing, in order to be sure that the damage is correct. When we scan the patient with ultrasound, so we can see that the part of the nerve which was treated is much bigger than the rest of the nerve. So this is actually a good sign that we have provoked Valerian degeneration. And also, as I said, mentioned in the beginning, with cryolysis, you cannot damage epi and perineurium, and then the nerve regrows in the same tube. So that's why I find actually cryoneuralisis much better for the patient instead of radiofrequency. My personal opinion and experience. Yeah.
I think.
Thank you.
Okay.
Igor, Przemek, please. You can comment, please.
I think all the methods have their place.
Yeah.
If I will give you an example, very short example. I'll try not to talk very long. If you take a patient who has an oncological patients, the idea of treating oncological patients is to give them a pain relief which will last as long as they live. That's the idea behind it. So the palliative treatments, that's an area where I would say RF. Okay, I wouldn't do cryo because I'm forcing the patient to come like 3 times to my private practice before he dies to make a cryo, and then he comes again and he comes again, and we have to make the procedure once again. This is a absolutely palliative way of treating the patients, and this is the place where RF is surely dominant. The second thing I would like to say about RF is something which RF has a longer time of regeneration, which means the patient stays longer pain-free. I'm putting that in the air because this is the most used argument. It's not that I comply with it, but if you have a patient and he comes 24 months later for a treatment of the facet joints, and then you have a patient where you make a cryo and he comes 6 months later, okay? Then for these 24 months, you have to repeat it very many times. And that's why some people say, okay, I'd rather stay with RF. But what I would like to emphasize for these persons is that you still, in these patients where you make RF, you have a very high possibility, and this we don't talk very loud about it, of causing neuropathic pain. And then there's no way back. It's there, which you cannot do with a cryo.
Okay, yeah, it's calling nightmare,
for
the doctor.
Yeah.
Yes,
it's
yes,
not point to compete, you know. It's point to complement the both treatments.
yes.
So yeah,
That's
there's the
both you guys. You are almost answered for my next questions. What was in clinical practice when the thermal lesions are preferred and when the cryoneurolisis is chosen? That's I will little bit change the focus for these questions, because the
Mhm.
list of the indications for the thermoablations, even it's peripheral PRF or the classical one, is pretty clear. Numbers of the indications of the cryo, it's changing because it's rising every year. We can find new indications mostly for the peripheral nerves, what is the very exciting. But I little bit changed the scope my questions, and I would like to ask you, Igor, about that. Uh, Maybe that's kind of your practice experience. If you have a, do you get any patients who visiting your practice, your clinics, when the thermoablations procedure failed or generate some additional pain, or patients was not so enthusiastic for these outcomes, and you, with the patient's consensus, decide to make a cryo afterwards?
yes, actually, I have patients who already tried radio frequency, and 1 2 years ago the pain is back, and now they want to try cryo because they say that they had a very bad experience with radio frequency with neuritis afterwards, which lasted for a long period of time. As I said, the issue is with these patients that we it's difficult to some of the nerves is very difficult to target again and stimulate the nerves in order to confirm the correct diagnosis. So what I found actually very interesting now is that I get patients referred from the doctors who do radio frequency, and they say, okay, we have tried radio frequency, now we and I don't offer cryo. Now we want the patient want to offer cryo, or the doctor want to see how cryo works.
Igor, can I drop in into what
Yeah,
you
yeah,
said?
yeah,
Those are
please.
the patients. I don't think this is neuritis. Maybe you had patients with neuritis. I think it's neuropathic pain. And this is
Yeah,
the moment
maybe.
where you
Yeah.
the changing of the method to cryo is the right thing to do. So uh, I think the guys who are doing the RF, when they treat a patient, they make him facet joint denervation for the first time, and they do it for the second time. The first time, the patient is very happy. The second time, the time from the moment he was pain free after the procedure shortens, and they try again to do the RF, and the RF doesn't work then because he has neuropathic pain. So what they do is they send you the patient because they don't know, maybe they don't know what to do
What to
further
do?
on.
Yeah.
Uh,
Mm.
but the idea, although they don't know what they're doing the right thing because the RF is strictly for nociceptive pain, and you can cause neuropathic pain with it, which means the better method here is the cryo, because it not only is for nociceptive, but it's also for neuropathic.
Neuropathic pain. Yeah,
So it,
that's correct.
yeah, right.
Dear gentlemen, because my list of the questions and the topics is 50%, and time it's almost done. I have a last questions regarding for both of you, how the ultrasound guidelines changing the situations with the both procedures, right? Because the cryo and the RF is usable for the ultrasound guide. How the situations is changing?
I don't know.
Przemek,
Maybe you would like to say something, or should I say something? Well,
Przemek,
well,
No, I
please.
yes.
I'm using all the methods the whole time, and we still don't have actually fixed guidelines. We have only they're not out. I hope we will have guidelines which will exactly define what somebody who starts with cryo should do. Um, but the most important thing is the cryo is changing the market for the patients, which means they have a better possibility, but they have to take in account that the treatment will not last so long as before. They have a possibility which allows to treat peripheral nerves, which is almost impossible with RF. And the most important thing is, and actually Igor already mentioned it, even if we treat nerves which have a part of them is motoric, not only sensory nerves, the motor function comes back very fast. So what stays is the pain goes away. The motor function is for some time. The muscles lose on strength, but it comes back, and I see that in my patients in about 4 to 8 weeks. So you don't have to be nervous if you're doing, for instance, a cryo of a knee, that you do the lateral inferior genicular nerve, because if you freeze the peroneus, it comes back, which you never had with the RF. And I do that, and I never have a problem with that. So that's opening the possibilities for the patients where we can use it more. You can you have the peripheral nerves, you have the mixed nerves, you can use it. You have less neuropathy. So altogether, the only problem with the cryo is that it doesn't last so long.
Okay, Przemek, thank you so much for your take-home messages. Yes. Let's give a chance to answer it, Igor, regarding ultrasound guided approaches with the cryoneurolysis, with some take-home messages as well. Thank you.
I will say actually that ultrasound is must with cryo if you want to achieve good result. This is because when you do cryo, you have to localize the nerve, you have to see the nerve and put your needle on the nerve. This is why cryo is growing up now in popularity, because now the doctors are much better to use ultrasound and see the nerves. And this is where we're trying to shift doctors doing radio frequency to do more cryo, because it's easier to do and quicker. So I would like to say ultrasound. See the lesions for how you create the lesion and everything. So I would say that I would like to say
visible on time. Okay,
ultrasound is must. Yeah.
Sorry to finishing this part of the discussions. Thank you so much, Igor. Thank you so much, Przemek. We stay, Przemek, together for the next panel, what will be dedicated for your procedure. Thank you once again.
Thank you. Thank you for the invitation.
Thank you very much.